very loud. Can you guys hear me? I would not normally yell to a patient like this, but I'm going to try to speak loud so you guys can hear. I wonder how long until the fan turns about a minute and a half. Okay, so the fan will eventually turn off. What I'm going to show you guys is basically how 2 EMTs are going to come in on a patient who has reportedly fallen, and this patient who has taken a fall, we'll just say he's unconscious, because that doesn't matter right now, because I'm doing the same thing whether he's conscious or not. All I want you to see is 2 things. The first thing is going to be what we call our rapid blood sweep. All I'm looking for is life-threatening bleeding and really checking to see if the guy's alive. That should take about 5 to 10 seconds. That's how fast that is. We're gonna immediately follow that up with our primary survey. Our primary survey is going from the neck to the head all the way down to the toes. And basically we're looking for injuries. That's all we're doing. I'm gonna verbalize what I'm doing, and I want you guys, when you're practicing, to verbalize, because you need to know what you're looking for. Today, all we're doing is exposing you to it, and you're gonna get some hands-on in practice. So, are you able to lay down? Yeah. So, I would be wearing a mask, but I'm not, so you guys can hear me. So, we are EMTs today. We're working overtime on 8164, so we're not operating as medics. We would be wearing blue shirts. So we get a call, 155th and Aurora, man down on the side of the road, possibly unconscious, but not knowing, secondhand report from a passerby, a good Samaritan calling 911. So the way we're gonna start is Nick and I are going to the call. I'm not even going to go into all the things we're gonna say. All I want you to see is the mechanics today. So normally we would be saying BSI, body substance isolation, scene safe, one male patient on the ground. I'm not gonna do that right now. So all I want you to see is how we put our hands on. So Nick normally would be starting to get vital signs. He's kind of my scene safety because he is the person who does blood pressure and all that. I'm gonna walk up. First thing I'm gonna do is come up. Hey sir, can you hear me? So we got an unconscious patient. Upgrade to medics for us. I'm gonna just do a quick blood sweep. Going under the head. To a medic.
We have an unconscious patient.
Under the body as far as I can. Looking for blood. Checking my hands, making sure I have no blood. Okay, no blood. So we have confirmed that this guy doesn't have life-threatening bleeding. It took about 10 seconds at the most. The next thing I'm gonna do is it's gonna be a little bit more, it's gonna take a little bit more time. So I'm gonna verbalize what I'm doing. So being that this guy is unconscious and we think it might be trauma, I'm gonna be worried about the neck. I don't know if he fell or not. So partner, can you take C-spine stabilization? So my partner takes C-spine. First thing I'm checking is I'm working my fingers up the center of his spine, checking to see if anything feels abnormal, any floating little bones or step-offs. I don't find that. So I'm gonna put my hand on his head, and I'm looking for open injuries, quickly going around his face. I'm looking for JVD, jugular venous distension, making sure his trachea is midline. Pushing down on his shoulders, pushing down on his chest. I'm going to expose his chest. We'll say I'm looking at bare skin, looking for equal rise and fall. Pushing in on the ribs. I'm just pushing one time down in the center of the belly, seeing if there's any rigidity. Pushing in on the hips, in from the side, down. I am moving the legs. Checking for broken bones. I would check the genitalia only if there was a necessary reason. And going down here, since he's unconscious, I can't have him do anything. Going up to his arms. And I'm just saying I didn't find any signs of injuries. So that, talking loud, I don't know how long that lasted, but maybe a minute or so. That is just really basic, looking for quick injuries. Later on, you guys are going to get what's called your secondary assessment. Your secondary assessment will be a very detailed examination. So we'll be using a pen light, looking in eyes, looking in the nose, checking behind the ears. All this is really intended to do is check for life-threatening injuries. If we see a life threat, I need to address it at that point in time. So if I walk up to the patient and he has no pulse, what am I going to do? CPR. If I walk up to the patient and he has a pulse but he's not breathing, what am I going to do? Breathe for him. Bag valve mask. Exactly. If I'm going down his chest and I expose his chest and notice a hole in his chest, I can do a life-threatening thing. You guys will, or a life-saving thing. I'm going to put in occlusive dressing on it to make sure that there's no sucking the air into that wound. So if we see life-threatening items while we're checking the person, we're going to address the life threats. If I have an arterial bleed, I'm going to put a tourniquet on. If I have a minor bleed, I'm going to avoid it. If I have a bone sticking out of the leg, I'm going to notate it in my mind, but that is not life-threatening. So we're going to address life threats and otherwise notate things. Your secondary assessment is normally done later on. So more than likely, you're in the aid car. Hey ma'am, we're going to the hospital now. I'm gonna just give you another, just fully check everything. I don't want you guys, this is where the biggest mistake in all of this that I see when teaching, especially newer folks, is this. They get confused between a very detailed physical exam and a quick check for life threats. So you're basically doing 3 exams. The first one is the blood sweep, okay? 10 seconds. The second one is the primary survey, a minute-ish. And then the third one, the secondary exam, I will be honest with you, a lot of times the patients aren't gonna get a secondary exam. If you turn the patient over to AMR, that's them. They are gonna be doing that while taking the person to the hospital. If you turn the patient over to the medics are gonna be doing that exam. So you don't always get to a secondary exam, but if you're taking a patient from North Bend to Overlake Hospital because they fell and they live in Bellevue and wanna go there, then with that individual, you are doing a secondary exam on your way to the hospital. Make sense? Okay, so I just wanted everyone to see that, and then you're going to get further instruction from your instructors today. Anything to add?
Questions? It'll make more sense as you start doing it, okay? Next thing we want to do is I just want to show you quickly, okay, set up for the high-performance CPR situation, okay? The best way to teach this is breaking it down step by step. So today, all you're going to focus on is doing your pulse check, okay? We're also going to start working on, because it's a 5-week class, you've also got to manage a radio, okay? So verbalizing the radio, and we'll show you what that looks like. And this is how it's going to go. Robert, you want to help me out here, buddy? Okay? So Robert and I are working on an aid car. We get dispatched, same kind of deal. We're going to use the same scenario. It's unconscious, unresponsive. We don't know why. Okay, cool, that's fine. We can have our little conversation when you get sick, not sick, and understanding en route. We're going to kind of come up with a couple plans, right? If I'm in charge, I've got the AED. So if that's the case, Robert's going to be starting CPR. Okay? So that's just the roles to set up with 2 persons. Okay? As we approach the scene, same thing that MSO gave today, talked about. BSI, is my scene safe? I see I have one male patient. He appears unconscious, unresponsive before I ever touch the patient. Okay? He's sick until proven otherwise because he's not responding to me. Okay? As I get down, we don't have the AED today, but I'll have my AED. I'm going to place the AED somewhere up by the head. Okay? And while I'm doing that, I'm going to tell Robert, hey, bare the chest and hover. He's unconscious, unresponsive right now, and I'm thinking we're going to be doing CPR. So he's going to bare the chest and hover. While he's doing that, I'm checking a pulse and looking for breathing. Right? Pulse check no more than 10 seconds. Okay, as I do the pulse check, all right, Robert, he has no pulse, start CPR. Robert's going to start doing CPR. Now I take a second, take a breath, dispatch, 8163, upgrade this to a cardiac arrest. Okay, stop. Okay, upgrading to a cardiac arrest because I want my friends coming to this party, need some help. So you saw how that works. Your partner starts CPR. I don't do a pulse check and then start CPR. okay? Because there's time for me to go from here to then move into a position where I can do CPR. We want to eliminate all unnecessary interruptions. So Robert, bare the chest and hover. I'm doing a pulse check. Okay? No pulse. Start CPR. Dispatch, aid 163, confirm or upgrade this to a cardiac arrest. Okay? And then all we're gonna have you guys all do is about a minute of CPR just like this in this position with this person staying here just for now. So you understand the mechanics, okay? You can stop. With the mechanics of CPR, you wanna be as close to the patient as possible, okay? As close to the patient as possible. You're leaning over the chest. The position is nipple line right in between. Hands on top of each other. I don't care if you do it like this or you want to interlock, however you want to do it. But palm down right in the center of the chest, okay? Your fulcrum, your moving point is your hips, not your back, not your arms, not your shoulders. These lock out like pistons. They stay totally straight. He's going to get his body up over the top of the patient and you're trying to press straight down and allow straight up. So he's going to press down on the compression and we talked about it yesterday. That's saving the brain, because we're pushing blood into the body. On the recoil, we want to make sure he comes all the way up off the chest and allow for full recoil, because we got to get the pressure off the heart, because the heart perfuses itself on diastole, or that relaxation phase. If he does good compressions down and only comes up that far and just works from there, he's saving the brain, but the heart's going to start dying because it's not able to perfuse itself, because it perfuses on diastole, or the relaxation phase of the heart. Okay, so that's all we're going to work on today. Body mechanics and how to set yourself up to start. Okay? To go over the dispatch just real quick because we're practicing on it. If you are dispatched to something that's not a cardiac arrest and you need it to be a cardiac arrest, the terminology is upgrade to cardiac arrest. And like MSO was talking about, that's all you have to say. And you're going to get all the resources you need to handle that. You don't have to say, I need a medic, I need an engine, I need a ladder, I need PD. Upgrade to cardiac arrest if you were not dispatched to a cardiac arrest. If you're dispatched to a cardiac arrest, so it comes out, aid 164 and all the resources that are coming, it says CPR is in progress, or is there a suspected CPR going on? When you get there, because you've already got the cavalry coming, you confirm cardiac arrest if you find it. Okay, so dispatch aid 163, we have a confirmed cardiac arrest. That then lets know all the incoming units, this is exactly what we think it is. Okay, then the last part of that is you get there, it's a CPR in progress, or it's a suspected unconscious unresponsive. You get there, you go down and check a pulse. They've got a pulse, maybe they're breathing, maybe they're not, but they do have a pulse. Then it's dispatch, this is not a cardiac arrest. Okay, those are the three things that you're responsible for in relation to cardiac arrest, and we want you guys to be practicing this because in 6 weeks you'll be doing this. Okay, so again, not dispatch to a cardiac arrest, it's upgrade this to cardiac arrest because you were by yourself. So you've got to upgrade it. Okay, dispatch to a suspected cardiac arrest or CPR in progress, confirm. Dispatch, confirm cardiac arrest. Okay, and then lastly, if it's not that, but if you're dispatched to it, dispatch, this is not a cardiac arrest. Okay? We're no longer using, and we're trying to get rid of it, because dispatch is no longer being educated this at NORCOM. Plan A is not a term we use anymore. You're going to hear it from some crews, and we still do hear it. Some people say that because that Plan A is the Seattle, King County, that was the CPR. It was a Plan A, and we were running a CPR. But the newer dispatchers are not being told that terminology. Right? So it's cardiac arrest is the terminology we use. Okay? Cool? Good. All right, let's get to your stations, however it was, and remember the rotations. 1, 2, 3.